Okay, okay.
Yeah, I think we can start. Attendance right now is 9. Welcome all that are joining right now. Sorry we are starting a bit late, but you understand we are in the month of Ramadan. And our speaker today had to break the fast, then join us. So sorry about that. We will go again, we'll go direct to what we are in for today. Remember our topic today is exploring adult vaccination against invasive pneumococcal pneumonia in the pharmacies. So our speaker is Dr. Nadia Butt. She'll be coming in at after I introduce her, but I briefly want to take you through what we'll be doing in today. As usual, you remain muted during the presentation. Questions are asked on the question and answer tab. Feel free to use that during the presentation. We expect to be through, even though we started late, we expect to be done before 7:30. So we will not waste any time. Remember, even as to log on to your PPB portal, subscribe to this event. It's under the same name you've seen up there. It's the event, you'll find it on the last page of the activities. So it is quite easy to find. It's the last event to be uploaded. Anyone else attending as a FarmTech, you're invited as well to subscribe to the event, still on the same, under the same name. All our webinars are recorded and we upload them on the our YouTube page for reference and for our members to make reference anytime they want. So we're going to have a speaker presentation, the speaker presentation by Dr. Nadia. A brief introduction of Dr. Nadia, which was not included in this slide. She is a pharmacist, once was CEO of PSK, an active member in different committees and also a member of HOPAC. So she's quite conversant with this topic because I'm aware she trained also as a vaccinologist. She took a course on that, and she's passionate about primary healthcare in the pharmacy, in the community pharmacy. So without wasting any time, I'll invite Dr. Nadia to make her presentation. Then after that, we'll have the presentation by our sponsors, the Pfizer group that has a vaccine on COVID currently, and that is known to have rose the dead before. So we are glad for that. What can't they do if they've already raised the dead? Thank you so much. Karibu sana, Dr. Nadia. The floor is yours. I'll stop sharing so that you can project your slides.
Dr. Nadia, you're muted. You're muted. Dr. Nadia, you're muted. Doc? You're muted. Eric, maybe you can assist.
Yes, Eric can unmute.
Hello?
Hello, Kim.
Hello, Dr. Nadia, you need to unmute yourself. I'm trying to unmute you, but it can only allow me to ask you to unmute yourself. Please unmute yourself.
Then call Daktari direct.
Have your message. Can you hear me now? You're okay? Perfect, thank you.
Yes.
Doc, share your screen.
Okay. Good evening, all. Can you hear me?
Yes,
Yes,
we can.
Perfect, perfect. It's good I didn't go far. So good evening, everyone. Thank you for having me with you tonight. And I'll try to make this as brief as possible, but at the same time, make it informative. So tonight we're discussing the pharmacist role in vaccination. And in particular, my passion is community, and that's where I'm based. I have my own community practice, and we deal with vaccinations, although COVID is one of them that we're not allowed to administer in the community sector at the moment. I think it's important to start with the basic facts around pneumonia. And what we realize is that approximately 1 million deaths for children occur annually. And approximately half of these mortalities actually stem from Africa, which is quite scary. It's estimated that the pneumococcal pneumonia makes up about 175,000 hospitalizations annually in the US. 30 to 40% of these are adult community acquired, and 50% of these are hospital acquired. So we're actually aiming to keep people out of hospital. And some pneumonia arises from the influenza. So let's discuss some brief facts. The Streptococcus pneumoniae is a gram-positive bacteria. It has a polysaccharide capsule, and there's 90 serotypes. The bacteria invades the lungs as pneumonia, the brain as meningitis, and the blood as sepsis. So the sepsis would be in the form of bacteremia. And 50,000 cases in the US per year are bacteremia. And about 300 to 400 cases per year cause fatality from just pneumonia. Milder conditions occur. For example, otitis media does occur. But pneumonia in general is one of the leading causes of infection globally. So it's imperative that we deal with this at the ground level. It affects babies and the elderly the most, although people like us in healthcare, we're exposed, so definitely we're at high risk. And today, because Pfizer has the vaccine for pneumonia, we're discussing Prevnar 13, and it's a vaccination that protects against pneumococcal bacteria. And the first vaccine was discovered in 1977. So if we look here, this is a chart explaining the trends in invasive pneumococcal disease among children. I know we're speaking about adults. Oops. Yes, Eric? Yes, Eric? How come it's not sharing? Where did you heard me, but you didn't see the screen? Okay, let me try again. I don't know why it's doing this right now. Let me see. Megaly, etc. If you look at this, this map, it was from a site where Save the Children, UNICEF, are working together to report on the Kenyan situation in terms of pneumonia. And you can see that on the left, it says it's the biggest killer, yet it's forgotten. It claims the lives of more than 800,000 children under the age of 5 every year, more than 2,000 every day. Of course, these statistics change according to where you're looking. But if you look at this map, you can see I'm not excellent with my geography, but I did do my research on this one. So the darkest areas, if we look at the darkest areas, those are the highest number of cases. And you'll see that they're in the regions of Tana River, Turkana, Homa Bay, Lamu, and even Nairobi is in there. But on the other hand, the lowest rates are found in Kajiado, Wajir, Isiolo, Mandera, Garissa, Samburu, and Laikipia. So now the question stems, why do you see such a trend? And I discussed this prior to this webinar tonight, and what we resolved was that perhaps reporting was not accurate, because we would assume Nairobi would not be the highest in terms of access. We have access and availability to drugs and also hospitals, and other places in Kenya don't. So this is a bit here and there, but nonetheless, these are the facts. Now, how do we say we're preventing pneumonia? Again, this is from the same organizations, UNICEF and Save the Children. And you'll see that the first way of preventing pneumonia is from breastfeeding. So it starts right at childbirth and nutrition. On the other hand, we have to take into consideration that water, sanitation, and hygiene is very, very important. Also, we have to agree that the number one way to prevent this is immunization. Also, there's a need to diagnose pneumonia. Lots of people are going into hospital with symptoms right now, and everything is pointing straight to COVID. Yesterday, there was a webinar about malaria. And when you listen to the webinar on malaria, you realize that, wow, these symptoms are overlapping so much, and it's so easy to just overlook something like pneumonia. Malaria is overlooked a little bit more right now than pneumonia, but there is that case where you can have pneumonia and not have COVID. Recently, a family member did have pneumonia and they didn't have COVID. So it is possible, and we need to look at these things individually, even if we have suspicion that they're together. And we need people to go into hospitals. I think people are so terrified of going into hospitals right now that even if they think they're sick, they will not go. And of course, upcountry in those isolated regions, access is such a problem that people don't seek help. They do their own things. They take herbal medications, etc. They boil a little bit of this, a little bit of that, and they drink it up, and that's their concoction. For some, it may very well work, but in the presentation yesterday, malaria, they were saying that, yes, people were boiling things and drinking stuff, and it did help them. But in cases of pneumonia, pneumonia can go from bad to worst within minutes, within hours. So it's important that whenever you have any symptoms, we have to get those people to hospital. We have to keep on, reminding people, don't take things so lightly, and don't be afraid to get help. We need to continue to reiterate that with our clients. So what's the reason why we should vaccinate? I think it's very, very simple. And we know from the beginning, immunization is the way to decrease hospitalization, decrease severe illness, and reduce the incidence of mortality. And right now with COVID, you'll see that everybody's saying that's our aim with the vaccine. With COVID vaccine, people are saying that any vaccine is better than no vaccine currently. Not to say there's a problem with the vaccines, but nonetheless, any vaccine is better than no vaccine. So these are the things that we are aiming at. PCV13, it protects against 13 of the serotypes of pneumonia. And they're the most common serotypes that we find. So it works wonderfully in that sense. It's proven to be effective and has decreased the rates of pneumonia in children and adults. In Kenya, the predominant serotypes are serotype 1, serotype 6B, serotype 14, serotype 5, serotype 23F, and 19F. So now that we know why we should vaccinate, who do we vaccinate? You'll see that definitely we need to vaccinate everyone at the moment, because there's the overlap between pneumonia and COVID. We should make an effort to make sure that the high-risk populations are vaccinated first. But at the same time, we need to look at who's being exposed and who needs to be vaccinated. So adults, they take the pneumococcal polysaccharide vaccination, and it's recommended in adults 65 and above. ages 2 to 65, people with medical conditions, and 19 to 65 for those who smoke. So smokers, we know their lungs are compromised. So definitely that would be one of those groups that we need to look at. And also elderly are being exposed. And in children, it's already part of the CEPI program. So the pneumococcal conjugate vaccine is recommended for babies up to 2 years old. So they actually get that vaccine before they're 2. And we hope it carries out through their lifetime. But of course, circumstances change. People become immune compromised. They become smokers, et cetera, et cetera. So things change along the way. Now, contraindications to any vaccine. A lot of this thing is very generalized because we do see this with all of vaccines, but a contraindication is a condition in an individual that greatly increases the chance of a serious adverse effect. So when is the situation where we will not give the vaccine? If a person has a severe anaphylactic or life-threatening reaction from a previous pneumococcal vaccine or to the diphtheria toxoid, if they have encephalopathy, if they're pregnant. It seems that most of the time, all vaccines are contraindicated in pregnancy, except we see a lot of tetanus. We do give tetanus to pregnant ladies. Other than that, even flu vaccine can be given, but we see a lot of the time, all live vaccines, we keep away from pregnant women. Now, precautions is a condition where there's a chance of a reaction being increased. So it's not completely contraindicated, but we have to be careful. So we have to see if there's a case of severe illness going on. And if the person got a recent blood product, for instance, if they've taken blood because they were anemic or their blood counts are low and they had to be supplemented, that's something really, really to think about. And what we would say is that do the benefits outweigh the risks of actually taking the vaccine? But let's look at the most common adverse reactions in children and adults, because the actual side effects or adverse reactions are the same for both, actually. You'll see some people, mostly in kids, you'll see decreased appetite and irritability in children, although I can attest to some adults being irritable too. Drowsiness and restless sleep. More in children, I believe, and tenderness or swelling at the vaccination site. I think that goes for everyone. Only children can explain it, but adults do find that their arm is getting tender, especially with the COVID vaccine, but with other vaccines also. And actually my practice at my pharmacy is if someone has their vaccination, I actually sit them down because we have to keep them for 10 to 15 minutes after the vaccine to make sure that there's no reaction. I give them an ice pack and they walk out being very, very comfortable. It's not a must. It's not something that is a must, but it's definitely helpful for some people. Others experience diarrhea and vomiting. Okay, if we go now to the suggested vaccination schedule for Prevnar 13, the recommendation is for children at 2, 4, 6, and 12 months old, and it's it's 4 injections for children, but in adults it's 1 injection at any given time. The dose is just a 0.5 ml intramuscular injection. So in adults it's in their deltoid, and for children it's in the anterior lateral thigh. And if you look at the composition, it's quite interesting, the composition here. You'll see that, like we said, it's Prevnar 13. So we hope there's 13 here, and there is. So we look at the ones that were most common, and you'll remember that I indicated that it's serotype 1. Then you'll see 6B here. You see 14, you see 23F, and you see 19F. And these are the ones that actually affect Kenyans the most. So we're covering our bases when we're using this vaccine. And if you look at the CEPI program, which is the Kenya Expanded Program for Immunization, you'll see here that in the early primary years, you'll see BCG, OPV rotavirus, and then you see here pneumococcal vaccine. But in the KEPI schedule, they're giving it at 6, 10, and 14 weeks. So they're giving it as 3 doses. But again, the protection is so high. We're working with the children and we're actually protecting them at a very, very young age. And they're also given as part of their routine vaccinations, the IPV. Yellow fever is given too, and measles, HPV. HPV is given more often now than it was long ago. And then in the adult vaccination schedule is just Hep B and tetanus and typhoid for those who travel. But now pneumonia is being considered very much. So we say that when we're trying to vaccinate people, we have to look at the high risk groups. So these are special occupation groups. And you'll see here that the healthcare workers are there, people who work with carers are there, emergency and essential workers are there. And you don't necessarily see hepatitis written there, but it's important. But you'll see, pneumococcal vaccine. You can see that here on this list at number 5, alcoholics and smokers are at extreme high risk. So those are the people that definitely we will not shy away from giving them the vaccine. And then immunocompromised individuals. All of these categories of individuals would be the target population to vaccinate. So we have cancer patients, we have our HIV and AIDS patients, we have diabetics, asthmatics, and other chronic diseases. And again, we focus on elderly. So anybody greater than 50, in other countries, it's greater than 60. Nonetheless, either or, it's still okay. And travelers, depending on where you're going, and you can see that some places like when people are going to Saudi for Hajj and Umrah, that they do take certain vaccines that are important, like yellow fever. And people with, those are the people that need to get their vaccination. I was initially going to be having a poll run at this point, but we'll run it at the end and have a brief discussion on it. But what we need to do is look at what the differences are between COVID, pneumonia, and the flu. And we realized very, very quickly that a lot of the symptoms overlap. And again, malaria can be put in the 4th column to say what other diseases overlap with pneumonia. And COVID, respiratory illness, pneumonia, respiratory, flu, sometimes, yes, people have trouble breathing, sore throat, fever, chest pain, acute respiratory distress, loss of appetite, malaise and fatigue, excuse the spelling, increased heart rate. So pneumonia has all those symptoms. And COVID, when you go to COVID, you can add a little bit extra with the loss of taste and smell, things that you wouldn't typically get with pneumonia, headaches, a dry cough more than a wet cough, but wet cough is present in some. And again, there's a sore throat. With pneumonia, not necessarily a sore throat. But again, there's so many of the symptoms that are overlapping. It's hard to actually figure out what you're dealing with. Even with the flu, someone will have fever, chills, fatigue, cough, again, body ache, congestion, headache, and a sore throat. And all of these can be caused by a virus. So COVID is definitely caused by a virus, as we know, and transmission so far, although we had so many different discussions and WHO had said so many different things, but main transmission would be droplets. Pneumonia, again, person to person, droplets, it's in the air. But pneumonia can be of the bacterial nature, viral, or fungal. But we see the one that's affecting Kenya the most, or in Africa, is actually the bacterial pneumonia. And it's actually something we can treat, and we can treat it very, very effectively if caught early. Flu, initially everybody thinks they have the flu, so they don't jump to the conclusion that it could be pneumonia or COVID. And that's where we're actually making the biggest mistake right now. It's better to be on the side of caution, but at the same time, I think our systems are lacking in the sense that to get any sort of COVID vaccine, a COVID test done, it's so expensive that the average person can't actually afford to get tested. I think this is something that we have to work on with the ministry, etc., to have funding for those people who can't, who are sick and need to check for COVID. But in terms of pneumonia, x-rays, blood tests, all of those things are there to actually confirm pneumonia. So we can actually deal with it very, very well. But at the same time, we are pharmacists, but we shouldn't overstep our roles. We should lean on our doctors, our colleagues who are highly trained in listening to the chest and looking and interpreting these x-rays, etc. So we need to work as a team, definitely. So if we look at COVID versus pneumonia, the COVID vaccine it's from a non-replicating chimp adenovirus vector, and co-administration of other vaccines is not recommended by CDC. Actually, a colleague probably listening today mentioned at CDC that said that if you have the COVID vaccine done, then you have to wait 14 days until any other vaccine is given. Although it's not a live vaccine, but still, because if you were to give the pneumonia vaccine and there were side effects or adverse reactions, then you wouldn't know where it's coming from actually. And anyone who suffered from COVID-19 may still take the vaccine. So if you've had COVID, you can still take the COVID vaccine. But pneumonia, on the other hand, it's an attenuated, weakened virus. It's not live. It's a polysaccharide bacteria, and co-administration is allowed. So pneumonia vaccine could ideally be given with the flu vaccine at the same sitting. But when you want to do COVID, we have to space it out. So even if it says 14 days, 14 days to 30 days would be ideal. And right now, if you haven't taken the COVID vaccine, it might be actually better to take the pneumonia vaccine first, because those people who do end up in hospital, even if they go with community-acquired pneumonia, even if they don't go, with community-acquired pneumonia, they might get hospital-acquired pneumonia. And also they might get COVID if they're in hospital too. So it's a bit of a tricky situation. And the recommendations across the world are Pfizer, which has 2 doses, Moderna, which has 2 doses, Janssen, which has 1, and AstraZeneca is the only COVID vaccine in Kenya right now, which has 2 doses. In certain countries, AstraZeneca has been suspended along with others. But the recommendation for pneumonia now is Prevnar 13. And children are ideally supposed to get 4 doses, but under KEPI we give 3. Excuse me. And adults are just given a single dose. And Synflorix is there also, and that's for children, and it's 3 doses. Adults are not the primary consumers of Synflorix, but Pneumovax is given as 4 doses, and to adults above 65. So if we were to look at what to do first and what not to do, of course, WHO has recommended COVID vaccine, but in our category, where we might not be at that age limit to go and get the vaccine, as healthcare workers, definitely we're included. But if there's people of our age group who can go for the vaccine, it may be a good idea just to take the pneumonia vaccine first. So a little bit of a review on immunization. Immunity is built by exposure to antigens, which trigger a response to produce antibodies. It's simple enough. Antigens can be in the form of proteins or polysaccharides, and they're live or inactivated substances which produce that immune response. Antibodies are protein molecules, immunoglobulins, produced by B lymphocytes to help eliminate antigens. Active immunity is built by an individual's immune system and is produced by vaccination, whereas passive immunity is transferred from human to human or animal, etc. Inactive vaccines can't replicate and require multiple doses. So if we compare live vaccines to active vaccines, it's good to have a sense of which ones are live and which ones are inactive. So the live viral vaccines are MMR, measles, mumps, rubella, varicella, yellow fever, oral polio, rotavirus. And the live vaccines, which are bacterial, are oral typhoid and BCG. While the inactive vaccines, we're looking at tetanus, diphtheria, pertussis or pertussis, if you like, influenza, hepatitis A and hepatitis B, the poliovirus, human papillomavirus. So those are your inactive vaccines. COVID and pneumonia, both are being inactive. And when you're giving inactive vaccines, even those, if you want to do them in the same sitting, it's fine. There's no problem with that. You can co-administer them, but not with COVID. And inactivated vaccines can be safely given to immune compromised individuals, like people who have HIV or AIDS. It's contraindicated in individuals with allergies to a component of the vaccine or encephalopathy, which we discussed previously. Live vaccines, we can't co-administer them. So we give at least 4 weeks in between. And then the scenario where you need to give a live vaccine and the person has taken an antibody blood product. If the live vaccine is given before the antibody blood product, then you can wait 2 weeks and give. If the antibody blood product is given first, then you have to wait 4 weeks. And any 2 live vaccines, we separate by 4 weeks just to be safe. The only exception right now is yellow fever. You can correct me if I'm wrong, but yellow fever can be given less than 4 weeks from a live vaccine. And again, live vaccines, we're very careful with pregnant women because there's actually no data on it. It's not that perhaps it would be safe, but again, if the benefit outweighs the risk, then definitely we'll go ahead. And if not, we'll stay away from the vaccination while the mother is pregnant. And again, the contraindication being allergy to a component of the vaccine, encephalopathy, and immunosuppression. Now, when I'm doing vaccination in my setup, there's a lot of things that we go through. And you can see there's a checklist. This is my checklist. This is my go-to checklist. I have every client fill this out. And it's asking very, very basic questions. Are you sick today? Do you have any allergies from the components of the vaccine or food, etc.? Any serious reactions after having a vaccine? And a lot of these questions are so important, but right now in the current scenario, they're not being asked. When people are going for COVID vaccine, I've just been told their blood pressure is being checked and maybe their temperature, because everywhere temperature is being checked. But in the pharmacy where we can actually take control of the situation, I would suggest checking sugar, blood pressure, and now to go through this checklist with the patient. So have them read through, answer the questions, then you can assess whether you can give the vaccine or not. And in 1 second. Yes, okay. So as far as giving vaccines for pharmacists, there's no policy that directly states that pharmacists cannot administer a vaccine. And those who have trained have been administering vaccines. All over the world, globally, you'll see in pharmacies, pharmacists are giving vaccines. And it's important that we bring it back to the pharmacy in Kenya. More of us need to train, more of us need to administer vaccines in our facilities. It's a more conducive environment. People are more comfortable. It's quick in and out. It's more personalized. And there's been about 3 or 4 years where the Kansas to Kenya program was introduced by the University of Nairobi to train pharmacists on vaccination. It's an intensive 5-day training. And actually, the Kansas University students come down with their professors and the dean, and they take us through every aspect of vaccination, from how to space them out, which vaccines to give at what time. And then they take us through actual vaccinating each other. And technique is a huge thing right now, because we've been seeing the way people have been vaccinating, and they actually get to the wrong level. They're injecting in the fat rather than the muscle. And these are things that we really need to take into consideration. And I think when we're doing it in pharmacies, we'll be more diligent. So what's our role as the pharmacist? To provide information to our patients. So when a patient comes in, especially newborns when they're coming in, you can actually ask them, because in the community pharmacies, that's the private sector now. So people are not following the KEPI immunization schedule. They're going through the private sector schedule. And so it's so important when someone comes in, a new child has been born, you ask if they've actually are going to be getting their pneumococcal vaccine. And it's important to identify the special groups of individuals that we were talking about. So if we have a database where we know that someone has gotten their, let's say, flu shot, then we can follow them every year and we can ask them or remind them to take it again. With pneumococcal for adults, it's a matter of just informing them and letting them understand the importance of taking it. So anybody who comes in, you can speak to them. And if you see that that person themselves is not taking, maybe they have an elderly in the house, and give the elderly person in the house the pneumococcal vaccine. In the very small chance that you come home sick, we don't want that elderly person to now contract pneumococcal disease, because it can go from bad to worse very, very quickly. And as a healthcare worker, regardless of if you have or haven't received the COVID vaccine, it's important for us to take the pneumococcal vaccine, because the hospital pharmacists are being exposed in hospital, community pharmacists are being exposed in community. Even in industry and academia, maybe currently in academia, it's not the case as schools are closed or universities are closed, but even at the industry level, pharmacists are in there and people are working. So wherever you're in a situation where there's masses, we have to suggest that it's important to take the pneumococcal vaccine. So at the end of it all, we always say prevention is always better than cure. There's a couple of questions. There's a few questions that I wanted to go through with a poll. So I think we'll proceed to the poll. If someone from the Pfizer team can help me, then we can run that poll and have a discussion. Is Eric there?
Yes, I'm here, Nadia.
Yes, I'm going to run the poll because that's the end of my presentation, but I'd like to run the poll and then we can have a brief discussion around that.
Okay, just a moment.
Should I stop sharing? Would that help?
Not really. Just a moment.
Okay, so I'll just wait for the team to run this poll.
Because actually the person who was supposed to run is the one that I want to talk to right now. Can we skip maybe as I handle that? Can we go maybe to the Pfizer presentation? Do you allow us to do that?
Sure. That's fine.
Okay.
Of course, Eric. No problem.
All right. Thank you, Nadia, for the presentation. We've all seen the importance of that course for those who want to take it. Dr. Nadia is the community pharmacist at Health Aid at the junction of Mpaka Road and Muthithi Road in Westlands. Feel free to visit, but if you are looking for a prescription only medicine, you'll not get it from her. You have to come with a prescription. So I'll allow Hilary Kemboy to make his presentation. Hilary, it's your turn now as I handle the poll. Nadia, you can stop sharing.
Thank you very much. Yes. Thank you very much. Let me just share my screen. I want to see if you can see. Can you see my screen? Hello. Hello.
Yes,
can you see my
Hilary,
screen?
yes, Hilary, we can see your screen.
Okay. Thank you very much. Okay, can I continue? Is
Please
it okay,
proceed.
Kim?
Yes, proceed.
Fine. Yeah, thank you very much. And I would also want just to thank Dr. very much for a very good and elaborate discussion that she's made. And my name is Kemboi Hilary, as you can see there, from Pfizer Vaccines. I'm from the vaccines team, and we are very proud in Pfizer to actually be also leading in terms of providing solutions. And one of the solutions, which is actually our breakthrough, bringing breakthroughs to patients and also offering that breakthrough to the world at large. And as you can see also in terms of COVID vaccines, we are also trying to bring those breakthroughs. So one of the breakthroughs that Pfizer offers is actually Prevnatine, as Dr. has said. And Prevnatine is actually our pneumococcal conjugate vaccine. And as you can see there, is actually approved all the way from 6 weeks, the way Dr. said, up to the adults. So as you can see, this our position today, we're actually focusing on the adult vaccination. And as you can see there, we are saying, take a step ahead.
Hilary?
Yes?
We are not able
Yes.
to see your screen. We can't see it. Sorry for interrupting.
You can't see my screen?
We
No,
can't.
Hilary, we can't see your screen. We can't.
Okay. Let me just reshare again. Okay.
If you're having challenges, I can show on my side. Oh, it's coming on.
Mm-hmm. It's coming on?
Yes, presentation mode.
Yep.
Okay, good.
So is it
Proceed.
okay?
Yes.
Thank you very much. Yes. Sorry, everyone, for that. So I was actually saying that in Pfizer, one of the solutions and the breakthroughs that we are offering is Prevnatine. And Prevnatine is actually our PCV vaccine, that is pneumococcal conjugate vaccine. And as you can see there, it's approved from all the way 6 weeks, the way Dr. said, for children, up to adults over 50 years of age. And this is actually the ones that Dr. was saying that it contains the 13 valent. That is why we're actually saying Prevnatine. Because we know in our market, we have the PCV10 and also PCV13. And today we're actually talking about our Prevnatine. So Prevnatine comes in that pre-filled syringe, as you can see there in that picture. And why is Prevnatine, the way Dr. said, currently is being advised? And also from the questions I've also read, someone, a comment, not a question, somebody also talking about the PCV23, the plain polysaccharide. So this is actually the difference in terms of the plain polysaccharide vaccine and the conjugated vaccine. Because initially the plain polysaccharide vaccine came, but because of the good nature of the conjugation, because when you actually conjugate, is where they actually add a protein carrier to the polysaccharide of the bacteria. That one actually brings a better immunogenicity as compared to the one which is plain. So what is the difference? You can see there the difference in terms of polysaccharide. It contains just the polysaccharide antigen alone, while the other one, that antigen is actually covalently linked to a carrier protein. And then when it actually comes in terms of immune response, it induces the T cells independent immune response, the plain one, while when it's conjugated, actually it induces the T cell dependent immune response. And the most important one is the stimulation of the B cells to produce antibodies. For the conjugation one, once the conjugation happens, it actually stimulates the T cells to produce B cells, which actually produce antibodies and generate immune memory. So when you actually conjugate the vaccine, it actually brings that memory cells, so that we don't need frequent immunization. As maybe some of you can remember, the one that when PCV, the plain polysaccharide was being used, the schedule for adults was or anyone was being given after every 5 years. So that is also some of the reasons why Prevnatine actually has a very good advantage, or rather conjugation has a very good advantage over non-conjugated vaccines. So what is Prevnatine and what are the serotypes that are contained in Prevnatine? You can see there we actually have 13 serotypes. And this is actually a slide just showing you the PCV7, which was initially then PCV10, currently the one that Sari said that is being issued at the KP for kids. And then we have now Prevnatine. So Prevnatine has 3 extra serotypes, which are not there in the PCV10. And why we actually advocate so much in terms of Prevnatine is because when you're actually talking about immunization, the more you protect, the better the outcome. And Dr. actually mentioned that there are over 98 serotypes of strep pneumonia. And of course, there's actually the common ones. And as you can see there, Prevnatine contains all the common bacteria, the serotypes that actually their prevalence in Kenya. That one I will not repeat, but I would actually say and emphasize the importance of the 3 extra serotypes, which is available in Prevnatine. So the serotype 3 is actually a very important cause of invasive disease and is also associated with the serious disease, especially in community-acquired pneumonia. So serotype 6A again is actually been found to be resistant to antibiotic, the same way with 19A, which is also a leading cause of pneumococcal disease and also increasing resistance to antibiotic. So this is actually the reason why I was saying the more the serotypes that you cover, the better the outcome in terms of preventing pneumococcal disease. So this is also something very interesting, and actually, Dr. thank you very much for elaborating it very well, because vaccination is actually a basic strategy for prevention of pneumococcal pneumonia and invasive pneumococcal disease. And by the way, it is actually very important that Kenyans, we should also try to embrace, and it actually comes from us informing all the HCPs, informing the population out there so that they can be able to know. And once they know, it is easy for people out there to make informed decision that, yes, I want this vaccine. And that is why Dr. said, what is our role as pharmacists? One of the things is actually to tell them. And Prevnatine comes in handy when we're actually talking about preventing pneumococcal infections. So Prevnatine actually is actually the way to go. And it is very important for us also to ensure that all vaccine preventable diseases, we are able to minimize it. So what actually are the risk groups that Tari emphasized a lot? And I can just, again, go through it very fast. So comorbidities as well as advancing age. Apparently age is actually a very big risk factor on itself for pneumococcal disease. So subjects with these conditions face higher likelihood of invasive pneumococcal disease compared to the healthy ones. So what are these groups? So the first group is actually the people with lung diseases, people with COPD, patients with asthma, patients who also smoking because it actually affects a lot their airway. So they have 5 to 17 times more likely to develop IPD. Patients with cardiovascular diseases, you can see there, they actually also, it increases their likelihood of developing IPD. Diabetic patients, again, this is actually a very sensitive category of patients because we know definitely because of the high levels of blood sugar in their, blood glucose in their blood, it actually helps to proliferate the bacteria inside their system. Another category of patients is actually the immunocompromised. These actually include all the patients who have chronic kidney disease, HIV, immunosuppressive therapy, maybe patients who are actually taking immunosuppressive drugs, maybe like those patients who actually have cancer, they're actually taking drugs which is actually affecting their immune system. So all these patients actually are candidates that we should be able to recommend them to actually get Prevnatine. And as you saw in my slide initially, it is actually one injection. That's the beauty about Prevnatine. We really don't need to give several injections. One injection is enough for adults. So smoking apparently is also the strongest independent risk factor for IPD, and immunocompetent adults aged of course, the adults from 18 to 64. And this is very categorical because we know that smoking is actually allowed for adults from 18 years of age. So this is actually category of patients, again, we really advise starting from our homes. If we have anybody who is actually smoking, because sometimes you actually know the fight of smoking can be very difficult. So how do we help them actually have a better life and comfortable life? We actually advise them to get Prevnatine, which will help them a lot. A very interesting factor, if you can see my slide, again, is influenza infection increases susceptibility to pneumococcal pneumonia by 100-fold. Apparently, influenza, again, once you have influenza, it increases your chances so much of you getting a pneumococcal infection. And as you can see there, strep pneumonia was actually found to be a common secondary infection following a primary upper respiratory viral infection and infections due to influenza virus. So meaning today you get influenza infection, the possibility of you getting infection from Streptococcus pneumonia is very high. And as you can see, this is actually a study that was done, and it was actually comparing pneumococcal pneumonia versus influenza in terms of hospitalization of adults. And as you can see there, this is actually a study that was, it's based on the Center for Disease in CDC and also Influenza Hospitalization Surveillance Network. So this is actually a very credible data showing you that pneumococcal disease actually leads to a lot of hospitalization as compared to influenza. And we've seen clearly that once you get influenza infection, it increases your chances up to 100-fold of getting a pneumococcal infection. So as much as we're actually telling and advising all the patients to take the influenza vaccine, let's also advise them the benefits of actually also taking a pneumococcal vaccine also. So PCV13 may be given concomitantly with the seasonal quadrivalent inactivated influenza vaccine or trivalent inactivated influenza vaccine. So this is, and I remember even Dr. is saying it, they can actually be given together. So if you actually, the patient comes in for influenza and you tell them about Prevnatine and they're able to afford and maybe they're able to take it, it's okay. Just give them, you don't need to have any spacing between influenza vaccine and Prevnatine. So just a single dose, the way I said, is enough. So this is actually a very interesting data. This is actually a study that was done on Prevnatine, and it was actually looking in terms of efficacy in prevention of invasive pneumococcal disease and also pneumococcal pneumonia. So this is actually a study that comes very handy to show you the importance and actually the benefits of Prevnatine. It is actually called CAPITA study, and the CAPITA efficacy results is actually showing that in terms of the primary endpoint and the secondary endpoint, all of them, they're actually looking in terms of successfully reducing the occurrence. And as you can see there, in primary endpoint, it actually, there was 46% reduction of in prevention of the first episode of vaccine type pneumococcal community-acquired pneumonia. And then the secondary endpoint, again, it's still the same, 45%. And this one actually, it was about prevention of the first episode of vaccine type, bacteremic and non-invasive pneumococcal community-acquired pneumonia. So this is actually two which was actually looking in community-acquired pneumonia. And then there's also the secondary endpoint, which actually was also showed a very good results in terms of 75% reduction. That is actually the secondary endpoint in preventing first episode of invasive pneumococcal disease. So this is actually a very good study showing you the effects of Prevnatine once it was introduced in the community. And actually it was actually a very good study to show you the benefits and actually how efficacious Prevnatine was. So statistically, it was actually, there was a significant reduction in the first episode of vaccine type, pneumococcal pneumonia. And why are we saying vaccine type? The way Dr. mentioned, apparently there are actually several other serotypes that can also cause a pneumonia, or there could be also other reasons which they can cause. But this one is specifically for the serotypes that is contained in Prevnatine. So we're only looking at those 13, which are the more frequently causative serotypes that is causing pneumonia. Another interesting, again, study that was also done is actually looking on the effect of Prevnatine in preventing hospitalization. And I remember Dr. actually said one of the major reasons why should we vaccinate, one of the reasons was actually to reduce hospitalization of our patients, because we know once we actually manage our patients with Prevnatine, it lowers very much the occurrences of pneumococcal infection in invasive pneumococcal disease. And these are actually patients that maybe they could have gone to the hospitals, but now they are not going to the hospital. And again, one of also very good reasons for vaccinating is actually lowering the severity of the infection. So once the severity of the infection actually is lowered, it means a lot of people are not going to go to the hospital. And as you can see there was actually very good vaccine efficacy against hospitalization. And there was actually 75% reduction in vaccine type community acquired pneumonia, and 70% against hospitalized non-bacteremic vaccine type community acquired pneumonia. So this is actually a very good, and as you can see, again, all the patients over 65, this was specifically for adults over 65 years of age. So as we said, age alone is also a factor. And then most of these guys who were included in the study, again, had one comorbidity, the ones that we're actually talking about. So, and it actually showed a very good result. So this is actually some of the benefits and reasons why we should advise our patients to take Prevnatine. So my parting shot, I would actually say, vaccinate now. Why should we wait for those patients to get to the hospital? Well, while we know that hospitalization actually means more cost. So let's just break this silence of pneumonia. And as we say, what starts silently can actually be life-threatening, and we don't want any of our patients or any of our people that we know to be in that situation. So the good thing about, as I say, Prevnatine, it's only one vaccine for the adults, and they don't need to actually repeat. So this is actually our API, and this is information that we can give you on request. So any further information that you need on our brief prescription information, please feel free to contact any of us. And here is actually our contacts. So thank you very much from Pfizer. We really appreciate your participating this afternoon. So you can actually contact myself through 0793-289-409 or Sophia Mwavita at 0702-295-996. Please feel free, call us at any given time. We are there for you to give you any information that you might be able to need. So my parting shots again, I'll say the way Dr. said, it is actually time that also pharmacists should be able to have, and we don't able to advise for vaccination, and we don't have any restriction from PPB to vaccinate. So if you're able to vaccinate, please, let's make a healthy Kenya. Thank you very much.
Thank you, Hilary, for that presentation. Yeah, I am sure I've seen questions that are directed at you. So you can go through the QA tab and see if there are some that you can answer. And if there are some that you want to answer live. I've gone through the questions. We have some 21 questions. I don't know why some people want to ask. Hello?
I've stopped sharing.
You've already stopped sharing, which
thank
is
you,
okay.
Thank you.
Yeah.
Yes.
So I've gone through the questions. We have 20 questions now. I've seen some questions have already been attempted. If you're asking a question as an anonymous attendee, I'll not allow you to be answered, because why are you hiding your identity? If your question is too complex, it looks like a master's thesis or a PhD thesis, again, I'll not pick it. But we have some quick questions for Dr. Nadia. Dr. Nadia, there's an interest from community pharmacists to know. One from Dr. Edna Kubai. Thank you for the great presentation. What are the requirements as a community pharmacist to offer vaccine in their practice? And also Dr. Ben Ogonji is asking, how do you plan to roll out this program to all community pharmacies? It seems you've drawn interest from those quarters. Dr. Nadia, I'm sure you have a quick answer for that.
I can answer both of those very quickly. I think if you've been trained and have the skills, then you're ready to go. But in Kenya, again, we don't have a lot of these programs. It was the only one that I know of was Kansas to Kenya, run by University of Nairobi under Professor Gontai's watch. And it has been run 3 or 4 years in a row, and I participated in that program twice. The few of us that are in community sector that took the course are privileged enough to do this in their own setup. All you need is a fridge that you have temperature control with. And the way I do things is I book the patient, I take, I order the drug, and the next day when it comes in, I give the injection. So I don't have this waiting period, and I don't stock myself in general. And if you have the skills, use them. There's nothing that the board or CAP 244, there's nothing stopping us from vaccinating. Only problem occurs with yellow fever, polio, and COVID. Even that right now, we're working on talking to the ministry and seeing if we can be clinics, because apparently you have to be a clinic in order to give those 3 vaccines, which are a bit funny, that the condition applies to only those category and not the others. So I would say get trained, take that intensive course, and start administrating in your own pharmacy, but make sure you have the area and the facility to do it, and keep adrenaline by your side just in case if there's anything that happens haphazardly, at least you're prepared.
Thank you, Nadia. I think you've also answered Catherine Joroge, who was asking the same question. Hilary, back to you, and we don't want you to tell us, come to my inbox. Several questions arising. What is the cost of Prevnatine, and what is the cost of the vaccine, and how long does it last? And because I saw part of your presentation showed the vulnerable groups that should be vaccinated, while answering that, please comment on people on dialysis taking the vaccine. People on dialysis taking the vaccine. Yeah, go ahead.
Okay, so the first question I will answer is actually the price of Prevnatine. So the retail price of Prevnatine is 4,405, 4,405. Yes, so that is actually the trade price in which we are selling from all our distributors. And you can get a Prevnatine from our distributors, that is our Laborex. We also get it at Sagifarm and also in McNaughton. So those are actually our approved distributors in the country. But again, you can actually get it at any retail pharmacies that are actually stocking, or you can just, I'm pretty sure with this group, I'm certain that there are actually some retail pharmacies who are also stocking. So availability is also very good here for Prevnatine. And then if I can comment on how long, Prevnatine, as I said there, from any person from 2 years of age, it's only recommended 1 vaccine. As you remember, Dr. showed very clearly in terms of the children vaccination schedule, which is starting at 2, 4, 6, and then 12 to 15 months. That is actually the booster. So for adults, it's only 1 injection, and that 1 injection lasts for the lifetime. You don't need to have a second, maybe booster. And in terms of patients who are actually on dialysis, that is actually one of our risk groups of patients that we are really advocate for Prevnatine, because patients who are actually on dialysis, they have a very high chances of pneumococcal infections, and we'll really be very happy that all those patients who are on dialysis should actually have gotten Prevnatine.
Okay, thank you, Hilary. I think your answer was comprehensive. You didn't tell us to come to your inbox. That's clear enough. I have another question. Maybe Dr. Nadia, you can talk about this. It's about, or even Hillary, because both of you have touched on it. What is the recommended age for adult vaccinations with Prevnar? Is it above 50 years or 65 years? Do you recommend above 65 years? Is there an age limit? I think that's what Peter Wino is asking. Whoever wants to go first.
Yes. So maybe I'll say something and then Dr. can top up.
Okay. Hillary first, then Nadia next.
Yes. So as I said, there's actually two situations for Prevnatine. There is the at-risk group of patients, and these are actually patients with the cardiovascular disease, patients with respiratory diseases, and all those category of patients who have comorbidities. This one actually, it does not matter because even a patient with 20 years can actually have asthma. And all those category of patients, we are advising them to have a pneumococcal Prevnatine injection. So for them, it's just one injection. And then there's the second group, which we are advising from 65 years of age. As you remember from our presentation, both Dr. and mine, we actually said age is also a factor. So for us, any person who is over 65, with or without comorbidities, we are advising them to have Prevnatine vaccine. Because during that time, again, the body immune system is actually also going down. So Prevnatine will actually help a lot in terms of preventing severe infections. Yes, maybe Dr. can add anything or is well?
I think the only thing I can add is I believe that we're considered vulnerable groups in the sense that our exposure is very, very high, especially those in hospital currently. So it may not be such a bad idea for the person who is healthy, but has an extreme risk. So we're looking at benefit versus risk. It's risky to be in hospital. It's risky to be in the ICU. It's risky to be with pneumonia patients. And there's a lot of them right now in the hospital. So those people who are being exposed, it's not a bad idea, even if you're in good health, to be taking it. Hillary can correct me if I'm wrong.
Yeah, you're very right. You're very right. Because patients actually who are at high risk, we also advise them to get Prevnatine.
Thank you, guys. I think you've done well on that. I think that we have one interesting question as we wind up because our time again, I promised that we'll end before 7:30. We won't go past 7:30. One interesting question. If one got PCV13 as part of primary immunization, is there need for a booster later in life? I think it has been answered live, but in the chat box in the QA tab, but I think it would be interesting for others to know. Do you need
Doc,
booster
I can take that.
Yes, Kennedy, please go.
Yes, there is need for vaccination. What you find is that vaccination in Kenya started in 2011, ideally, most even in the public sector. So you find that most of the adults are not vaccinated, that it's recommended. So you find that the ones who are actually vaccinated and fully covered are the ones who got it in the primary vaccination immunization schedule from the year 2011.
Okay, thank you, Kennedy. I think we've covered most of the questions. Again, I said if your question is more politics than science, we won't take it, but we have one interesting that Solomon Gekore is saying. It's not a question. As we enter the cold season and in the middle of a respiratory pandemic, your services should be mandatory for all members of this group over 50. I think it's this vaccination services. We have comments, many comments, good comments. The presentations were wonderful. Unless there's a question, Kennedy, you want to answer live that you've seen, or Hillary, you want to answer, I'll give you this opportunity. If not, then you can give your last comments as you wind up, kindly.
Okay, Hillary. I'll start. Okay,
Okay.
sorry. Okay, I can go first, then I hope it's okay.
Sure.
From me at Pfizer, I don't think there's any question that is looking maybe that I need to answer online, but I think we have tackled all of them as the ones you have read out. But my plea to the pharmacist would be, most of these patients, the patients with comorbidities, you find that most of them will be coming to fill up their prescriptions from your respective pharmacies. It may be medicaments on either diabetes, on either COPD, they're coming for the inhalers. It could be either even some who might be coming to buy the equipment for dialysis based on whether they're accessing it from the public or private. These are the patients that you target for vaccination. These are the same patients that you consider for vaccination. So please do not be quiet, have the discussions with them and vaccinate. Again, you mentioned about the cold season. You find that during the cold season, flu also tends to be quite prevalent. And as you have seen, there's always a correlation between flu and pneumonia. So as you vaccinate for flu, if you're vaccinating in your pharmacy for flu, you can also do a co-administration for Prevnatine. That is also advised. Thank you so much, and that's all from me. And thank you so much for your time. Appreciated.
Thank you, Kennedy, for that. I'll not take any further time. Remember to subscribe. I now invite Ivy, pharmacist, graduate management trainee at PSK, to close the meeting.
Thank you, Dr. Eric. I don't have much to add on. I'd like to thank Dr. Nadia for the great presentation and Hilary of Pfizer for the wonderful presentation too. I'd encourage all of us to get vaccinated. Santeni Sana from PSK, and thank you all for attending. Also, the recording will be on our YouTube page for those who'd like to go through it again. Asanteni and good night.
Thank you.